Trixie, do you want to carry on?
Thank you. Thanks, Jess. Yes, so as Jess said, all the feedback from today is valuable, and we will share back what we can find out for any questions we can't immediately answer this afternoon. This is our first event. There'll be other events in February and March, and then depending what comes out of today and what you'd like from us, we'll book further events after April. We will work with you according to what you would like to see. We do prefer face-to-face sessions. Of course, we've not been able to have them for some time, but let's hope we can do that in time to come. But as always, we're guided by the latest government guidelines around the pandemic. So I think now I'm handing over to Helen Jones.
Thank you very much, Chrissy. And I'm just going to say a little bit about integrated care systems and how we've got to the place we're in today. And apologies, many of you will know a lot about integrated care systems, but some people may not know very much. So just a refresher, integrated care systems, sometimes known as ICSs for shorthand, are here to bring health and social care organisations together so that we can work together more closely than we have done previously. And last year, as many people here know, the government decided that Glossop healthcare services would not move into the Greater Manchester integrated care system when that was established, but instead move into the Derby and Derbyshire integrated care system to enable that closer working. The name, as you will see, some of us are branded behind us today, but the name for the Derby and Derbyshire integrated care system is Joined Up Care Derbyshire, and the ambition has already been reflected in what Jessica has said, is to provide the best care and services for people in our area and make them as efficient and as effective as possible, so that people can get good outcomes from a health and care perspective. And the role of local authorities is critical to this. So it's NHS and local government and wider partners working together. And I think everybody who's already involved in Joined Up Care Derbyshire wants to offer a very warm welcome to people that will be joining us in the near future. And we're really pleased to be working with you. And if you're a local resident, working together on your behalf as well. It's important just to note that the decision to move healthcare to Derbyshire doesn't impact on any individual's patient's right to choose or to use services outside of their integrated care system. Those rights as they were still stand, and we are all working together really hard, as has already been said, and hopefully will be picked up throughout the discussion, to make this a change that builds on what's already happened for Glossop residents in the Greater Manchester Shadow integrated care system. So building on that work and the learning that's already happened, and moving forward into this Joined Up Care Derbyshire, building on that learning and development that's already taken place. So that's all I wanted to say by way of introduction to the integrated care system and why we've got to the place that we have now. I'm just going to hand back over to Chrissy, who's just going to update particularly around the timescales, which have changed recently for our kick-off point.
Thank you, Helen. In terms of the timescale, we have April as a target, or have had April as a target for some time. And there has been some discussion as to whether we move now to July for the boundary change in line with the ICB establishment date. At the moment, we are continuing to work to April until we are told otherwise. But further to what Helen's just outlined, we're not proposing to make any changes for the next 12 months at least, and you will continue to access services in the same way that you do now. But just a small caveat on that is that the NHS changes all the time, as we have and are experiencing with the pandemic. So some things can happen that we can't predict. But our commitment to you is to make sure that if there is change in the longer term, we'll be looking at it to make improvements to services, and we will create regular opportunities for you to have your say, and the aim is to co-design any changes with you. We're going to move on to Veena now to talk about what this might mean for you as a patient. Over to you, Veena.
Thank you, Chrissy. So yeah, when we got the news of this boundary change, so the GP in me being my patient's best advocate, the first thing was, will anything change for my patients? So obviously worked on it, engaged with the right people, contacted them, etc. And from all angles, it was really reassuring that nothing is changing for next 12 months for sure. So that was very reassuring that my patients will continue to get the care that they are getting at the moment. Then the clinical director in me wanted to know, yes, it won't change for next 12 months, but what then after 12 months? And then working with Derbyshire is not a new experience for us, because obviously, as you all know, social care has been with Derbyshire forever. So we have worked with them very positively in the past. So there were multiple forums and where we were being invited, engagement was there, building relationship, finding out what after 12 months, if at all, will change. So obviously, I wanted to be in places where I will be able to make sure that the best outcomes for my patients is being taken care of when making such decisions about move. And I'm really reassured that this is what everybody is working to. So I think we necessarily just said change can be unsettling, but change can also be an opportunity to make systems better. And this is how I see it, and I see no reason when we all work together. And that's why in the beginning I said this was much awaited forum to listen to our patients, our community, as to how things can be made better. And I have absolutely no doubt, having now worked with both sides and being part of the teams that are really working hard to make it seamless for our patients and for our community, I have absolutely no doubt that we will have great outcomes, and we'll have the best of both the systems to going forward. So obviously there will be Q&A sessions, and I will be answering. But I feel PPG will have a great role here to bring back to the systems as to what patients want and how we can move forward, incorporating all the best things. So I'm quite positive about it, and I think I will let Chrissy take it forward, but I'll be here to, if there are any individual questions, to answer them. Thank you.
Thanks, Veena. I think it's over to Steve now to talk to us.
Yeah, and thank you, Chrissy, and thank you, colleagues. So just following on the theme that Veena took us through in terms of the care that people get, the care that patients get. This is no great rip-up of any pre-existing plans. This is an evolution and a docking in, if you want to call it that, to the Derbyshire ICS. And it's not about imposition of ideas, it's actually sharing of good practice, and that's the real opportunity going forward. And I think it's important to be mindful of the context that we're doing this. Because as Winston Churchill once said, all things happen simultaneously, and it's important for colleagues on the call to just be cited in terms of where health and social care systems are across Derbyshire and across the country, basically, at this point in time of the pandemic. So over the last few months, as we're aware, that healthcare systems have been very challenged, balancing the response to COVID, maintaining the frontline services in terms of urgent and emergency care, elective care, and particularly those critical services around cancer care and trauma care and mental health care. And that's been a very sort of tight balance over the last few months. And in terms of COVID activity, our acute trusts, which in Derbyshire will include obviously Chesterfield Royal Hospital and University Hospitals Derby and Burton, but more widely the experience is the same. that COVID has consumed 5 to 6% of our bed capacity. Omicron's come along and has significantly upset this balance, and it's almost understanding what do we know about Omicron at this point in time. It's increased transmissibility, it's reduced generation time in terms of infections, and the impact it's had across health and social care and more widely into local authority and our partner services around staff absences, around outbreaks, and the increase in hospitalisation across the country has led to bedded capacity being extremely challenged, so that over 10% on average of bedded capacity in hospitals is consumed by COVID patients. That backdrop remains, and it's particularly challenging for colleagues in social care around maintaining services in the community and allowing patients to be discharged into community. So it's important to recognise the context of that and the responses that we've done collectively across the integrated care system, both in Derbyshire and in Tameside and Glossop, trying to increase NHS bedded capacity, supporting social care, and particularly the challenge I'd like to flag up on primary care in terms of the focus on the vaccination programme and the focus on meeting the demands of same-day appointments for patients going forward. And in terms of the vaccination programme, I'd just like to sort of congratulate and express gratitude to colleagues in Glossop for the tremendous work they've done in the vaccination programme, and we'll be linking in as a whole Derbyshire project on this, because the Derbyshire ICS vaccination programme has been particularly strong. And certainly in the wider Derbyshire context, we've done 2.25 million vaccinations since the start of the programme. And in terms of where we are currently, in terms of boosters, we've got to 83.5% of those over 18 who are eligible for a booster. And that's matched and complemented by the work that's done in Glossop. So we're really looking forward to joining our programmes together to continue the good work that's been done on both sides on this and the opportunities around that. And also to flag up, of course, the treatment options that are now available in the community for our most clinically vulnerable. So in terms of the context, we're doing this on a challenge basis, on a challenge background, but the ambition is the same. This isn't ripping up plans. This is merging our strengths, not sharing our weaknesses. And throughout that long list that you see in front of you in terms of primary care, acute services, elective care, mental health services, social care, the COVID response, patients on the ground, the ambition is to improve services. It will not change. It will be an evolution as we come together and build on our strengths together. And I'm hopeful that people on the call will recognise that. Change can be frightening, but change, as Veena said, can be a positive thing in terms of opportunities and building on our strengths collectively across health and social care. Thank you, colleagues.
Okay, thank you very much for that, Steve. I just want to come in at this point and just have a quick conversation about the fact that we're here today as the first kind of public session, and it's good to get here, as was mentioned before, to start this conversation and almost start this journey together, get everyone that we can together and make it a dialogue. We're mindful of keeping this presentation element of the meeting today relatively short so that we can get onto a Q&A and really hear from yourselves what's particularly of interest to you, so that can shape future sessions that we hold. This is just the starter today. As Steve was talking about the pandemic before and the restrictions, obviously we've been kind of limited to virtual meetings for quite some time, but moving forwards, we really are looking forwards to holding some more events and face-to-face. we're hoping to, and we will be kind of shaped by people's feedback, and we want to give the overview today. But in terms of kind of how we've got here, there's been a kind of communications and engagement group with some lay representatives from, voluntary and community groups, and interested people within Glossop, and then we've got the monthly public events, which today is the first of. We've not got a date for the February one yet, in part because we want to get feedback from yourselves as to what might be more themed events after this initial overview session that we've given, and that very much will be led by the feedback that we get from people. As well as these kind of monthly sessions, we're looking to get out there and get up to Glossop and have some kind of in-person, face-to-face sessions, smaller sessions as and when necessary. So we are kind of got a bit of a process, but this process is evolving, and it's going to be determined somewhat by the feedback that we collate from yourselves. And on that point, I'm just going to bring in Karen Lloyd, Head of Engagement for Joined Up Care Derbyshire, as to how we're capturing people's feedback and what we're doing with that feedback.
Thanks for the introduction, Lee. So as Lee said, my role is to make sure that I facilitate collecting all the kind of feedback that we get from Glossop residents into what I'm calling a listening document. So I've already started pulling that together, so I'll be able to share that with anybody that's interested, hopefully after we've taken it to the Comms and Engagement Steering Group on the 14th of February. And that document is basically starting to highlight the themes and concerns and opportunities that people are starting to raise as a result of talking about the transition of Glossop into Joined Up Care Derbyshire. So there's the usual things on there that you no doubt have concerns about. What are the changes to services? Will I be able to access the same services that I'm accessing now? But also, I think it's going to raise some opportunities to look at how we improve services in Glossop. So, there's a bit of a theme starting to emerge there around Glossop primary care service. I think it's is it George Street Centre or something? So, as more people start to talk about the transition and what they think the opportunities can be, what the concerns are, what their questions are, I'll start to theme those in that document, and the Comms and Engagement Steering Group will start actions we need to take as a result of that to make sure that you all do feel listened to and involved in the decisions that are being made.
Brilliant. Thank you very much, Karen. And then just to kind of hop on to the tail end of that conversation. So in terms of keeping people informed and making sure this is a two-way, open, honest, transparent process where we all kind of move along together, one of the things that we've done is created a central hub where we're going to kind of keep this information and feedback, and also give people a way to feed into. We recognise it's fantastic to have an event such as today. We'll do the in-person events. We've also got an online hub now, and I'll just bring that up on screen. If it comes up, hopefully you can see that, and I can put this link in the chat, but we've got a hub here where people can go to a website, and it just gives an overview of what we're trying to achieve here, the position we're currently in, and we're going to use this space as we go along to keep people informed. But you can also, it's a very engaging space, and it gives you kind of the functionality to ask any questions. We'll get back to you with answers to those, and we've got this up very recently, but we've also had some questions come through, I'm sure, off some of the people on the call today. So we are kind of hoping that as things move forwards, we can keep this space updated and make sure that it's kind of very open and transparent as to what we've been doing, where we're up to. We've got some features on here, such as, I mean, the upcoming events. We've got the event today. We're hoping to be holding another session in February, later on in February, with the date to be confirmed, as I say before, depending somewhat on the feedback that people share today. I can see there's some votes coming in now, just there, that on how people would like us to keep them updated about the topic. So we really do want to, from the off, make this something that works for everybody and have these different ways of communicating and engaging to keep people up to date and make sure that your feedback really does feed in. We've got some frequently asked questions on here, and like I say, I'll drop the link into the chat. I don't want to go on too much about this, but lots of useful information on here, and just another tool for us to be able to keep people informed. You can finally go on to this, click to follow the tab. That will prompt you to register, which is just putting an email address in, really. And then we can send you updates as and when there's another event or something like that. So just kind of informing people of that ahead of going on to the Q&A session. So we're going to hand over in a second. I'm going to hand back to Chrissy, and we're going to open the floor up to questions. If I could just go through, and I'm just going to have to stop sharing my screen for 1 second. I'm going to hop onto a different screen. We just wanted to make this session a way that as many people can have their say as possible. Now, how we're going to run this for the Q&A session is if people can raise their hands using the MS Teams function or put a question in the chat box, we'll pick those out and they'll be fielded to our panelists today. What we've also got, that I'm just going to share now, is a bit of an interactive approach. And I just want to explain how this works, so that whilst we're doing the question part of the session, people have also got the ability to share your comments, thoughts and feedback in another way, and this will come up. You can share this, it'll come up anonymously on screen. Now, the way to do that is you can simply get your phone and point it at the QR code, and it will enable you to share your thoughts and feedback when I move on to the next slide. Or you can join at the link, and I will drop those details in the chat box in the link. That's not for asking the questions, but we're aware it's now 2:30. We've got the question and answer session. If you could use the hand function in the comments box, you can also just share your general thoughts and feedbacks, ideas via this format, and that will enable us to go off at the end of this session, get the most data we can from you, and it will help to inform future sessions. So I'm going to hand back now to Chrissy, and if we can start to take some questions from the chat box and the hands.
Thank you, Lee. That's very comprehensive explanation of ways that we can put our questions in. So thanks for that. So we're going to open the floor now to your questions. We're going to run the forum until about 3:20, at which time we'll do a quick summary and then close. And Jess, did you want to add anything just before we open up?
No, I don't think so, Chrissy. I think that's been fairly comprehensive. I've seen a number of the questions coming into the chat, so I don't know if you want to pick those ones up first, and I'll leave you to chair and then just pull me in as and when.
Okay, thank you, Jess. So we've got a comment from Angela on the benefits. There's a question here from Deborah. Will the services offered at George Street Clinic be wholly for Glossop and Derbyshire residents, as it's often used for clinics taken up with Thameside residents and services can be hard to access? So I'm not sure if any of our
Do you want
panel...
me to take that one, Chrissy?
Oh yes, please, Jess.
I think in the very short term, there will still be a need for Tameside residents to access those services, because we won't necessarily have been able to replicate them in Tameside. But as time develops, we would aiming, obviously, to have our Tameside patients able to access things as close to their homes as possible and in their neighbourhoods. So that ultimately would provide additional capacity up at Glossop, but I wouldn't want to say a specific date or deadline for that at the moment.
Apologies, I was on mute. You'd think I'd know by now, really. Somebody has their hand up, but I can't see it on my screen. So can I suggest that rather than putting a hand up, we put an asterisk in the chat box, and then we can see where it's coming from. I'm not sure who had the question. Hand's gone down now. It might have been an old hand. Oh, it's come up. It's come up again.
It's Leslie Cernam. Leslie, do you want to come to your question?
Hi, yeah, I just thought I'd jump in while things were going difficult. Thanks ever so much for the presentations. And having been working with Derbyshire and with the transition team, I too think that we've got a lot of potential here and a lot of good stuff to come. Listening to what you were saying, Steve, I fully agree and understand we're talking about services, but when we're talking about an integrated care organisation and improving the health and well-being of our population, it actually includes very much the community. And the community must be seen as a service. It isn't just the NHS statutory duties that are there that are important. So we need to make sure that we're protecting all the stuff that we're building up really, really well. And that for us means that our neighbourhood team is supported, that our bureau is supported, that the work we're doing through the public health enterprises is supported. And we want to build up and make more firm the engagement that we have with patient groups and with the public. And that is out with, and actually I know Karen's doing some great work with Joined Up Care Derbyshire. So I just wanted to raise it because it's really important for us. And we've got some roles that support us in our community that we want to ensure are going forward. Well, I could name them, but I've already written to people stating them, but it's mostly our neighbourhood manager and the functions within the bureau. We need these as the hub to enable us to be able to move forward without being a burden to you, really.
Thank you.
Chrissy, can I, do you want to respond to that? Would that be helpful?
Yeah, that would be helpful.
I'd like to respond to that as well, Helen. I mean, first thing to say, completely recognise your concerns there. This is the opportunity, as Helen set out, in terms of moving now into an integrated care system, which includes both health and social care and wider stakeholders, particularly through the integrated care partnership, and that restructuring, if you want to call it that, into place and localities and neighbourhoods to capture that joint work across a whole system. So it's not working in silos around healthcare or social care or communities. It's that wider stakeholder engagement that you described really quite eloquently. And that's the ambition, isn't it, for that reach down into communities to tell us really what services we need at that level. So, sorry, Helen, did you want to come in as well?
Yeah, no, thank you, Steve. That's really helpful. And just to add to that, I mean, I think it's something many of us are really passionate about, that bit of the integrated care system that isn't the services, but is the community. And I think, you know, there are challenges, as Steve set out at the beginning, in health and social care at the moment that will not be solved unless we get better at dealing with health inequalities, about dealing with outcomes for people, improving life expectancy, improving life lived without long-term conditions, etc., etc. They won't be solved. And we know that people, not just people who work in services, but people who live in local areas are part of that solution. I mean, I don't know how many people here in their free time do voluntary work in their local communities, but I imagine it's a number of us. and all that is part of this journey to improve people's health and well-being. So I know a number of us that work in Joined Up Care Derbyshire are very involved in the work around what we call PLACE at the moment, which is hugely about ensuring that we apply this principle of subsidiarity, this idea that actually you do things on the smallest scale possibly, because we know then they will be more responsive to people's individual needs. And so that place-based working, which is developing in some parts of the country at different paces, but is very embedded in Derbyshire, is a kind of core part of how we will do this. But yes, the contribution that people make, their views, but also the contribution people make in their local communities to healthy outcomes is absolutely essential as we make that shift towards prevention and away from over delivering services that we deliver actually because we fail to keep everybody healthy, I guess. So I hope that was a very long-winded answer, but just to kind of reinforce that there is a lot of work going on in Joined Up Care Derbyshire around that. We want to build on the brilliant stuff that I know has happened in Greater Manchester around that. Absolutely.
Yeah, it is nice. Sometimes it's the way we use words. So when you talk about services, I don't get the feeling that you're talking about the community level. It's about the statutory services that have to be provided by health and social care. But actually, if we're talking about the integrated care, this is all of us working from the bottom up. And that's what I want to see in the language and the dialogue that's being used, to really respect and understand that, because only then will it be truly embedded in the integrated care organisation.
Yeah.
If we don't talk about it in that way, it isn't the way you think.
Yeah. Yeah.
Okay, thank you, Steve, for picking that up, and Helen, and thank you, Leslie, for the question. So I'll just move on to another question that's come in the chat box from Ruth. We've seen Stepping Hill and Macclesfield hospitals both exclude high peak patients at times. Are there any guarantees that Tameside General won't do that? Jess, I don't know if that's one that you can comment on.
Well, I'll try. I can't ever envisage that happening. Derbyshire have already got a contract with Tameside Hospital, and it's going to be significantly bigger with the Glossop contract going across. It's going to be about 15%. Derbyshire will be about 15% of Tameside Hospital's activity. Without that 15%, the ICFT would not be financially sustainable. I can't see any reason why anybody would want to exclude Derbyshire residents. Tameside Hospital also takes patients from Stockport. It takes the patients from Oldham and others. And no time during my time here, or have I ever heard previously, that Tameside have ever shut their doors to anybody who chooses to come to Tameside Hospital. I just can't ever see that happening. I do appreciate it. It did happen over on a couple some specific patient pathways in other areas, but I think it would be extremely unlikely. Glossop and Derbyshire patients are a core part of that ICFT. They have been for the last 25 years, and they want them to continue to do so.
Thank you, Jess. Thank you. Okay, we now have a question from Helen Robson. Helen, what's your question, please? I think you're on mute, Helen.
Thank you. Yeah, so there's been no mention so far about services for autistic people and people with learning disabilities, and there is a lot of ambiguity already between the two counties, where there's, because things like diagnosis happen in Tameside, and then the social care is in Derbyshire, and there's a lot of discussion in the community and concern about this. And as you mentioned, it would be useful to maybe have some meetings that are focused specifically on this. But I mean, very recently, Alderbrook Day Centre has closed because there's a shortage of care staff. So people from Alderbrook Day Centre can't attend. I'm not quite sure how long that's going to be for, and that is going to impact massively on the health of those people who can't attend. So yeah, so there's a huge area there to discuss, really, and all those extended services that people, because they're getting their healthcare in Tameside, can access because their healthcare is already there. I mean, for example, I attend I have an ME clinic that I can access in Stockport because I'm in the catchment area. So, you know, things like that, would that still happen? So yeah, I've got yeah, there's various things there.
Okay, well, thanks for raising that, and we are taking notes, as we say, and we'll feedback some more detailed answers. But I suppose my first response to that is we have a steering group between Derbyshire and Tameside and Glossop CCG, and under that are a number of work streams, and we're working our way through the various contracts and services that are available, just so we know what's being delivered and what needs to continue to be delivered. So that's as much as I know. I don't know if we have anybody else on the panel that's able to add to that.
I'd be interested to hear more, because I'm on various steering groups. I'm also I'm a director of Autistic UK, and I do a lot of representation in Manchester, and I'm not hearing anything. So whatever those working groups are, I haven't heard about those. The communication, I think, needs to be a lot more transparent.
Okay, well, can we take that away and come back to you on that?
Yeah, no, that's great. That'd be really good.
What the position is.
And I think that, you know, Ruth George's that specific point about Alderbrook, Ruth George has put something in the chat there that about 70 people from Alderbrook have been excluded for 2 years, and only 12 of the 83 service users were actually allowed back at all. And it is impacting massively. So I guess one of the questions is, if Derbyshire are now going to have control of that funding, will that be invested to keep services like that running again?
Could I come in? Would that be okay, Chris?
Of course, yes, please
come
do.
in. I mean, first to say,
Thank you.
Helen, I'm really glad you've raised this whole area as an issue. I think it is incredibly important, and maybe it is a theme we need to come back to in a future meeting.
Yeah.
Just on the issue of Alderbrook, just to be clear, because there's several things going on that relate to the number of people at Alderbrook. So one thing has been the impact of the pandemic, and the fact that there was a long period during which we couldn't operate our day services for infection control reasons, and because of the vulnerability of some of the people attending. So that's one thing. Another thing is the work that the council has been doing in social care, which aligns with the national agenda in terms of better lives for people who use social care services. And as a result of that, a number of people have chosen over time to stop using day services and have their social care needs met in different ways. So that's another factor. And then absolutely, as you say, in the last couple of weeks, we've had to make the decision to temporarily reduce services across our learning disability day services, to redeploy staff to work in our care homes, where the staffing situation has been unprecedented, really, in terms of the challenging with workforce being off sick or having to self-isolate. So just to assure, my hope is that is a temporary measure. It will be it will last for as long as it needs to, but we will not let it last any longer than it needs to. We wouldn't have taken that decision. I wouldn't have taken that decision if we hadn't had to really shore up our care home staffing. So that's a temporary position, but all those things are true. But I think in terms of the wider conversation about diagnosis and links to care, I think that would be valuable to return to. And were you talking particularly about children there, or children and adults?
Well, it's interesting that you've assumed that. It's both, and unfortunately a lot of adults are overlooked as well. And there's a lot of this sort of long term also can save a huge amount of money if that communication is going on, and as sort of preventative measures to for people not having to have support from mental health services. There's a lot of preventative work that can be done there, and I think it would be great to actually have, because there is a large community of autistic people and people with learning disabilities, to have somebody maybe at one of those meetings as well, some representation there, and people with lived experience too. But I mean, I'm hoping that things will improve with this, especially as we're going to be having these conversations.
Okay, well, thanks both Helens for that. We will come back to it, and we'll keep a note of the inquiry raised and make sure we give a full response. I'm just going to move on to a question in the chat box from Karen Rigg, who's asking whether she'll still be able to access long-term care at Tameside, or will it end in 12 months? I think we mentioned 12 months because it will take a while to go through all the pathways of care that we've got. It's not that at 12 months we're suddenly going to change everything, and certainly we wouldn't be expecting people to travel miles and miles out of their way. So we're not expecting changes to happen such as you described, Karen. And in fact, in Derbyshire, we do have patients flowing out to other areas for their care anyway, for example, to Burton in Staffordshire and to Nottinghamshire. So it's a fairly normal thing for, I think, nationally, that patients flow outside of their boundary area for care. I'm going to go next to Sarah Shaw, who's had her hand up. Thanks for your patience, Sarah.
Hello. This is really, as simply as a Glossop Dale resident, it's not terribly reassuring to hear that it's 12 months that no changes will be effected. It would be very helpful to understand what's envisaged after that. And although I realise that the situation is fluid, I doubt that there are no plans. And I think the idea of changes, particularly to healthcare, after 12 months, it would be very helpful if we could have some idea of what those may be, because otherwise it sounds from the reassurances as if this is some kind of paper exercise, and I somehow doubt that's the intention. But the reassurance, don't worry, nothing will happen, for 12 months actually isn't very reassuring without knowing what is likely, or actually what is planned to be in the pipeline. I know that nobody can say in perpetuity everything will stay the same, but I think it would be very useful to have some idea that the most significant changes for the most number of people around the delivery of health services, that is not going to change hugely for Glossop Dale residents.
Thank you. And yes, what I would say is we are not planning any changes at the moment. We really aren't. We are saying that things will stay the same, and you will see your same GP, you'll go to the same hospital, you'll receive the same care. Obviously, changes do happen in healthcare from time to time, not always led by a CCG or an ICB as we're going to become. But we certainly haven't got any plans for making changes now. So I know you're thinking that there might be something happening in the background, but that isn't the case.
So is it just for the average resident of Glossop Dale, is this purely a paper or administrative exercise?
Well, I wouldn't call it an administrative exercise, because we want to know what your views are on the move to Derbyshire, but also there might be things that you say you'd like to change. There might be things that you think could have been improved, and we'd want to hear about those, and we also want to hear about your concerns as well.
Sorry, Chrissy, can I just jump in on that?
Of course.
Well, yeah, just to say that I would expect that 99% of patients wouldn't notice any difference. That's what I would expect going forward. So I think we have to be really clear about that. This is an NHS reorganisation fundamentally, and it is moving the administrative lines to be coterminous. So health commissioning is coterminous along with council boundaries. And there are a huge amount of benefits of which that is associated, many of which we've just been putting workarounds in Glossop because we've already got those relationships. So the relationships between community care staff, for example, the community services staff and GPs and district nurses and all of those staff with council colleagues, there has been good workarounds put in place over the last X amount of years. What this will do is regularise some of that, because the health commissioning will also be done on that council footprint. So I think it's really important that everybody knows that for the vast majority of patients, there should be, or residents, there should be very little change. If anything, data flows should be a bit easier, communication should become easier, the way that Glossop is linked with the High Peak and other GP practices up there should become easier. The way to start to focus on inequalities, again, should become more targeted, because Derbyshire have got a huge amount of business intelligence that they can bring to all of this. So yes, no, all contracts have been rolled over for ease for 12 months, but that is just while we stabilise the system, and I would think it is extremely likely that Derbyshire would choose to keep the vast majority of those contracts going, because it already delivers a really good outcome, which is specifically focused for the residents of Glossop. Some things may change around the edges. It might be that there are other places in the High Peak or Derbyshire that want to do some of the schemes that we run in primary care, for example, but those sort of things will need to be addressed with Derbyshire and with patients in the future. But I think it is really important to stress that nobody has ever had a conversation about lock, stock and barrel changing services provision for patients in Derbyshire.
Well, that's very helpful. Can I just pick you up on something you said about GPs? Because I think at the moment our GP service, which is excellent, ties in obviously with Tameside. Will that move into Derbyshire?
Right, so what we have at the moment, so in Tameside and Glossop CCG, we have 5 primary care networks, so PCN, so groupings of GPs that work together, and we have 5 of those. We have 37 practices in total, but we have 5 of these specific PCNs. 4 of those are in Tameside, so we have north, south, east and west in Tameside, and then we also have Glossop, and we've always had Glossop as its separate neighbourhood, and we work with the Glossop practices as a collective. Yeah. So what will happen when the move is that collective of Glossop practices will move to become one of the PCNs, one of the primary care networks within Derbyshire, instead of in Tameside and Glossop, and we will go to be calling ourselves just Tameside. But in terms of, does it affect what happens on the ground in Glossop? No, because the Glossop practices probably have one of the best relationships I think I've seen in general practice. They all get on very well. They pool a lot of stuff. They're well led by Vina. They've got an excellent manager. They pull together. We do have different locally commissioned services in Tameside and Glossop that you may have in Derbyshire, and some of those may change in due course. Some of them may be rolled out across Derbyshire. Some of them may just stay in Glossop or whatever. That will have to happen in time. But the Glossop team will, instead of getting their support from Tameside and Greater Manchester will get their support from Derbyshire and the NHS region. And it was really gratifying to hear Vina and I had a conversation earlier today about how pleased she is with the head of primary care who she's liaising with in Derbyshire, Clive, I believe, and how that relationship is going from strength to strength. And so again, I think that's very positive, and I'm not concerned in any way about Glossop's ability and its PCN to make sure that their voice is heard.
If I might add in there, thank you, Jessica. It was really helpful. Clive Newman is one of my team, and the strengths of the Glossop PCN will be a welcome addition to the 15 PCNs in Derbyshire. We've got a very strong cross PCN primary care leadership structure in place, which is a really strong interface between commissioners and GP providers. And the strength of the Glossop PCN will be most welcome to collectively input into the wider Derbyshire system. So anticipate no change in the primary care services as you currently experience them, and we will be welcoming with open arms, as we have done already, as Vina has set out, the input from Glossop GPs.
Thank you.
Thank you. So thanks, Sarah, for that question, and thanks, Jess and Steve, for your input. And I think hopefully the reassurances given also answer the questions in the chat box from Claire and Keith about their care, which will be ongoing. Helen Robson has put a question in the chat box about whether there'll be an evening session, and Karen has responded there will be one, as well as a face-to-face one, which I think answers hopefully maybe something that I've just seen in the Slido questions you can see on screen, which are making sure that people that don't have digital access can be involved in these conversations. Andy's saying we'll share the outputs of the meeting so everyone can see and feedback or give any further detail. So that's great. I'm just going to have a look and see if there's any other questions that we haven't addressed. So, subject of learning disability services, will nurses from Tameside be transferred over to support people in Glossop, or will additional staff eventually be employed? I don't know the detail of that myself, Jess. I don't know if you can.
I do, if that's around the staff. So we have this legislation when there are any of these sort of changes, which are the transfer of undertaking protection of employment rights, basically, which is known TUPE, which is what happens when you are moving staff from one organisation to another. And there are very clear around TUPE. The main one being that in order for TUPE to apply, so if it was for me, for example, if I was to be TUPE to Derbyshire, I would need to do 50% or more of my work would have to be on the Glossop patients. In our current CCG, Glossop is 12.5% of our activity, 13% of our 12.5 to 13% of our activity. So there are no members, individual members of staff. So we all spend about between a 1/10 and a 1/5 to a 1/4 of our work on Glossop issues. So none of our staff individually apply under TUPE. So there will be no staff from Tameside and Glossop CCG transferring over to Derbyshire. However, Tameside and Glossop does lose the allocation for cost. So the amount of money that we get paid, each CCG gets, is based on a population, and we will lose that amount of money, and that amount of money will transfer to Derbyshire instead. So Tameside we're currently working through how we manage the impact of that, and Derbyshire will obviously be working through how much additional money they're going to receive and what they want to do with that funds. I guess that's an issue for Derbyshire to develop alongside the rest of the issues they have to take into consideration from moving from a CCG into an ICS. So so Tameside will be reducing cost because we will need to. Derbyshire will have some additional allocation.
Okay, thank you, Jess. Thanks very much. Chris Webster, is that you with your hand up?
Yes, good afternoon.
Good afternoon.
Just to take on from what Jessica was saying then, I think probably the question is who will still be delivering our community care, such as the district nurses, and the palliative care team, who currently are employed at Tameside, but do come and work in Glossop. Who will be providing the
Exactly the same now, Chris. Exactly the same. That Tameside Hospital neighbourhood team will be exactly the same team who manage your community services going forward. That's part of. So basically, if you think about it, so Tameside and Glossop, CCG, let's call it 200 million, right? 200 million comes to us on behalf of all of you patients, and we give, let's call it 150 million, the figures aren't right, but 150 million to the hospital in order to provide those acute and community services. As of post change, our income will drop, but Derbyshire's income will go up, and Derbyshire will continue to give the ICFT the amount of money. So let's call it £20 million. So instead of us paying over Tameside and Glossop, paying over 150 million, Tameside will only hand over 130 million. But if Glossop were already giving them 50 million, they'll now give them 70 million. It's really important that everyone kind of gets this. This is not about staff responsibilities or taking down a neighbourhood team or building up other neighbourhood teams. All of those staff who work in the community neighbourhoods teams in Glossop now will be paid and will be expected to look after those patients in Glossop as they do now. It's just where the funding comes from. So our allocation in Tameside and Greater Manchester ICS will drop, Derbyshire's will go up. Those team, we've spent eons developing that team up in Glossop, and I think we've got a cracking team up there. And the ICFT are totally committed to continuing to deliver and support Glossop services in Glossop to support those residents. So the palliative care team, district nursing team, all of those services that you receive from the hospital will be exactly the same as they are now. Does that help? Jessica. Does that reassure you? Okay, the only thing which I'm talking about in terms of the staff and TUPE, the only thing where that applies is in CCG, commissioning, finance, admin staff, which really, you know, 9 times out of 10, nobody really needs to worry themselves about.
Yeah, okay. The other thing, if I can just on the back of that, I think it might be a question more for Andrew Kemp and the head of communication and engagement. People in Glossop, if you try and ring Derby and Derbyshire CCG, you're very lucky if you can get a response. I tried several times over 3 days, and eventually I actually wrote to my MP and said this isn't good enough for somebody who lives in Glossop. And yet I can pick the phone up right now and ring Tameside CCG and get a call after 4 rings of the phone. And I think a lot of people in Glossop are very worried about the problem of communication, contact with people, who to speak to, who not to speak to. We're given 2 telephone numbers in Derby, neither of them get answered. We're given an alternative one in Chesterfield, and that goes to an answer machine. I don't think this really sort of fills us full of what's the word I'm looking for?
Perhaps reassurance or confidence. I'm very sorry to hear that. I'll follow that one up.
Yeah.
In the meantime, I'll put my contact details in the chat box here, so that if you're finding you're having problems getting hold of anybody, come straight to me and I'll resolve it for you. But in the meantime, I'll follow up and find out why you haven't been able to get through, because I know that our numbers are staffed right through the day, so I'm not sure why it's not being received or why your call isn't being picked up. But I will find out, and I'll come back to you and let you know.
Thanks.
Not at all. So I've had that problem.
Thanks, Sandy, and thanks, Chris, for your question. And hopefully Jess's response has also given some reassurance to Kate, who's put a question in about Tameside and services changing or not. And Helen Robson has suggested a focus group around learning disabilities and autism for children and adults. That sounds like a good idea. Ruth is asking, what about rehabilitation support places at Stamford unit? Will Glossop get some funding to develop them? The nearest are a few beds in Buxton. I'm not in a position to answer that directly. I'm not familiar with Stamford unit. I don't know if anybody in the panel or Jess can. Thank you, Jess.
Yeah, Stamford unit again will also be available as now for any Glossop resident who needs to have rehabilitation services. It's exactly the same.
Thank you. Okay, and I'm going to go to Claire now, who's got her hand up.
Hi, yeah, it was just, I work in mental health, social care mental health, and I'm just wondering about the access to psychology services, psychology support for people in Glossop, whether that's going to remain the same, and also inpatient care, is that going to remain the same, and the outpatients appointments, are they going, what's going to happen with those? I just want a bit of clarification, sorry. Don't know whether I missed it earlier.
Thank you, Clara. Well, I think the message has been nothing is changing at the moment. Nothing is changing for, well, I shouldn't say at the moment because I don't want to give the wrong message, but there is no change expected to be seen by the residents of Thameside and Glossop, so it should all stay the same. And I don't know if Jess would agree with that from your particular question, Claire, but that seems definitely to be our take-home message for everybody on this call.
I haven't got anything to add on that, Chrissy. I think you know, mental health is obviously sometimes different. In the fact that you can quite often have very long times in care, and it might be that at some point in time that that Glossop doesn't use Pennine Care Foundation Trust as it does now and moves more to a kind of Derbyshire-wide provider. But I think that would be a longer term thing because we have some complex patients in Glossop who use those services, who are well known by services, and I certainly don't think that there would ever be, well, I mean, I can't speak on behalf of Derbyshire, but I can speak on behalf of commissioners, is that we would be extremely unlikely to ever do anything which put any individual at risk, and so it might be that it was a phased approach if there was a change, but all the contracts, as we've said before, have been rolled over for 12 months. And I think that with mental health services, one should always proceed with caution and very carefully. But obviously there is a huge amount of investment in mental health, and a lot of that is going to be invested in outside statutory bodies with the voluntary sector and various other things. So it makes sense, I think, to review all of that in the round and connect it in different. You know, it might mean that there are different ways of connecting around mental health support and other areas in the future. It's possibly one of those areas that Derbyshire might want to consider going into the future, but nothing changes in the short term, and individual complex patients would obviously always be looked after.
Thank you, Jess.
She says, speaking very wildly, but that's on behalf of commissioners generally, because that's what we do. But I'm sure that Derbyshire would want to come in and support that.
Absolutely, Jessica. And, you know, I completely understand the questions that are coming through around service changes. This isn't about radical change, as Jessica set out. This has been extremely cautious with patient safety at the front and centre of what we think, and improvement of quality of care. So nothing changes. The roll forward of 12-month contracts will happen. Obviously, we need this stock take, and we need your opinions on this. We need these theme areas, and some of them that are coming through are great, where we can focus more attention on. So completely support what Jessica said on this, and I hope that gives some comfort and assurance to colleagues on the call.
Thank you, Steve. I can't see any more questions in the chat box at the moment, but we do have a comment on Slido around access to medical records via digital channels and being able to see treatment at particular centres. So I don't think we've got one of our digital representatives on the call today, but we'll take that one away and get a response on that for you. Okay, so we've got a little more time left. Does anybody have any other questions or comments they wish to raise? No? Okay, so it looks like we might be finishing a little earlier than planned. So I guess it's now for us to say thanks for all your input and for all your comments. As you know, everything has been recorded and we've made a note of it all. But some of the key points are, as colleagues mentioned earlier, contracts are being rolled over for 12 months anyway, but patients are unlikely to see any notice in the change of boundary. If there are any service developments in the future, we will work on those with you with full engagement and consultation, but nothing is planned for change. I've just spotted something come up in the chat box. Let me just have a look. From Helen. Many things currently aren't working.
Sorry, I think I've got a bit of copied and pasted.
Oh, right, okay.
From another meeting I was in. I'll read out the bit that is relevant.
Okay.
As well as continuity and focusing on improving care, there are many things that currently aren't working. So how do you propose to improve communication between Tameside and Derbyshire for people accessing social care when referred by hospital trusts in Tameside?
Okay.
And sorry, I don't know how that's managed, because I've got a section of something to do with another meeting.
Okay.
Yeah, so I think it's there. I think it's after Tameside, so ignore that bit after that.
Okay, so it's about people accessing social care. So Helen, I don't know if you want to respond to that, Helen Jones.
Yeah, I mean, it sounds like, Helen, there might be some issues behind you asking that question that I'd need to be aware of to be able to answer it.
Yeah,
all I was going to say is just before you come back in, that just to confirm that those relationships are already in place, as they are with a number of hospitals around the borders of the county, for discharge of patients to social care. So again, in that theme of nothing would change there, nothing would change. But clearly, if you're saying there's an inadequacy in the way that things are happening now, that would be really helpful to have that feedback.
Yeah, I think this is where you mentioned at the beginning that perhaps you might need to have focus groups on specific areas. And I hear a lot of people, and I've been involved with some mentoring as well, and people talking about issues that they've had where, you know, they've been in services in Tameside Hospital, and then when they're asked, you know, you need some support from social care, well, it's not our responsibility, you'll have to go to Derbyshire. So there's a bit of an abyss where people are lost, and often there are people who try to access services in Tameside and they're told you're not in the catchment area, and equally the same in Derbyshire. So I guess if you're do have some focus groups for some more specific things, somebody else mentioned mental health earlier, then that might be a really good forum to explore that further, to identify what isn't working and how you can improve things.
And some of that, Helen, is really helpful. Some of that sounds like the work to do as we kind of develop the work of the integrated care system as well.
Yeah.
Whether, you know, that's ongoing work, isn't it, improving things, but just to kind of provide that assurance that that, you know, social care Derbyshire currently provides that service for people who live in Glossop, so that won't change, in the way we work with the hospitals around the boundaries. You know, that established practice will continue beyond this particular change.
Yeah.
I do find it very helpful, these suggestions. You know, what are the quick wins here? We've touched on that particular question that Helen's answered. We talked before about the vaccination programme, how we work collaboratively on that. Quick wins, aren't they, in terms of service improvement? And it's not all about just pause and wait for 12 months. Actually, this can be quite dynamic as well. What are the quick wins that we can do? Problems that have been, embedded for a long time that colleagues have struggled with across borders. That there are opportunities here, as well as stability, which is the key message that's coming through today. Stability of service delivery across health and social care. Identifying those quick win areas as well is just as important through the focus groups.
And I think it's very important that we emphasize here that we are trying to develop a very strong neighborhood model of leadership and engagement. And that will be the real forum where there will be quick wins, like you said, Steve, and quick solutions, easy and not waiting another, because they will be communicating with each other. The leadership will be, and there will be engagement with different forums, voluntary, the whole picture will be there. So I think it will work very well and our patient groups and all will have a chance to engage as well. So like I said before, I see that as an opportunity to improve what isn't great, like our previous speaker said, and to keep what is working well for our people. And this is what I think is the onus on the leadership to take on board what as we go along, we are taking this suggestions and questions from our community. So I think we've done, first step is gone really well. We have collected so many points we have to work with and move forward. Thank you.
Thank you. Thanks very much. We've got another question popped up about funding for aftercare services, and will it transfer to Derbyshire? It will, won't it, Jess? Yeah. So that's a yes. Okay, so if there's no further questions, then we were just talking about communication, and there's something you can help with, all our colleagues on this call this afternoon. You'll know people in your locality, and you might have ways of reaching them that we don't have access to. So we'd be really grateful if you could sort of share the messages from today with those people and let them know how they can join in as described by Lee. We're really keen to hear any further topics you think of and want to talk about. We've got our next event in February. Lee, do we have a date for that yet?
We don't have a date. There is on the link in the chat somewhere people can sign up to register their interest for the date when it is decided. The reasoning we don't have a date just yet is we wanted to hold this session first, get people's feedback along with some of the other things we're doing and avenues people have been feeding in back via, and then we can sort out the relevant presenters and the people we'd need to get on that call. So after today, we'll be working away, and Andy will be working away to get a date agreed as soon as possible. We'll disseminate that information out. It will go onto the Central Glossop Hub, and we'll use all the previous contacts that we've have joined today's session. But to reiterate that point that you made, Chrissy, please do, this is starting the conversation off. Please do use all your local and community networks to kind of start spreading the word, because the more information we can get, then the better. And we can hold lots of little focus groups. Whilst we might have one monthly meeting like we've had to start it off today, we can then start to hold more individual little focus groups and face-to-face and all those things. So yeah, this is really the start of it. But yeah, that's the kind of logic behind it.
Okay, Brill. Thank you, Lee. So I think we're ready to close now, and just want to end by thanking everybody, both those posing questions and those answering them for their time today. I hope it's been useful for everyone. Jess, is there anything you wanted to say in closing?
No, I don't think so, but most of you know how to get hold of me, so if you do want to follow up at any point, please do so. I've just written a response to Claire Wild, because I don't think I addressed it properly by just nodding, so I've just popped that in the chat, which hopefully it makes sense. But look forward to turning up in February and March.
Yeah, okay, likewise.
Not
Thank you, everybody. Thanks very much.
Brilliant. Thank you very
Thank you.
much.
Bye.
Thanks.
Thank
Bye.
you.
Bye.
Bye.